is the bridge, but the coronary sinus is another bridge. So you can block everything else, and then the coronary sinus becomes your bridge to the vena Marshall, and then the vena Marshall back. So that's an important thing to know. Not something I think any of us really appreciated very well a few years back, but now just knowing that, it's a lot easier to go and get some of these more difficult cases. So this case illustrates one of the reasons I don't like anterior mitral lines in general. And this is a 68-year-old woman who had 3 prior ablation attempts, including a PVI, a roof line, anterior mitral line from the mitral valve annulus to the right inferior pulmonary vein. Again, I didn't do the first case. And she had recurrent atrial flutter associated with 1-to-1 conduction, really symptomatic. One of the problems with ATs. So we checked, and their pulmonary veins were isolated, and their lines of conduction were blocked. So actually, this entire lesion set was blocked from the first ablation. We induced a focal AT or a reentrant AT, you tell me. There's a reason I'm showing both atria here. And if you use Brad's trick, there's a little clue here that maybe this is in focal. So the 12 of you said it was focal. You can change your answer if you want. So this is another, another case where something looks like it could be focal, breaking out in the middle of the left atrium and up against a line of block, and then spreading out and going out into the right atrium like you expect through connections. It can't make it through this line. You can see that when the activation comes, it hits this line and stops. So this line's blocked. This line's blocked. It doesn't get to the posterior wall except going around and coming back the other way. So this is not, these lines are blocked. And this could just be a focal thing. Again, you have to realize though, when you have all these lines, the chances of it being a focal thing are much less. So just from an odds standpoint, there's a good chance this is reentrant. Again, you've got the whole cycle length of the tachycardia pretty much here. And you've got this period where nothing's happening from here to here. Just what's going on here? So where do you think this is coming from? Nishan probably could tell you. How do you get from the right atrium to the middle of the left atrial wall? Well, it is Bachman's bundle. So that's the other one. And this is one of the reasons I don't like anterior lines very much, because the one flutter that it can promote, particularly if it's to the lower part of the right of the veins, is it promotes this funny biatrial type of tachycardia where the circuit goes from left to right atrium or the other way around potentially, but I've usually seen it in this direction, around the valve, can't make it back in the left atrium around to finish the circuit around the valve. So it goes through the CS here, breaks out into the right atrium, climbs up the septum, goes through this little channel here, disappears, and then pops out here. That's Bachman's bundle. That's how it's getting there. So this circuit actually is using left atrium, CS, around the right atrium, up the septum, over Bachman's bundle. So there's a couple ways you could go at this. You could go epicardial and try to ablate Bachman's bundle. That's sort of the last resort kind of thing. You could try to get this touchdown. This, unlike the last case where that touchdown point was really small and looked much more focal, this is a very broad area. And so it doesn't really look like a focal tachycardia necessarily, because it has too broad an area of initial activation. And so if you ablate here, it's going to move to here, to here, to here. You'd have to take a large amount of ablating. And this is difficult to reach Bachman's bundle. It just keeps moving where the touchdown point is. So I wouldn't necessarily advocate trying to ablate it on this side. What we did do was we ablated it right. We ablated it right at that little choke point in the right atrium. We actually, with catheter pressure, before we even came on ablating, got it to terminate. We stuck it right there. Then we re-induced, and then we re-ablated, and it stopped again. So it wasn't fortuitous. So we were able to break the, turned out that it had to get through this little zone right here to get onto Bachman's bundle and over to the left atrium. So we actually ablated this tachycardia, which if you had entrained it, it would have been in this huge area in the left atrium from here all the way around. But this is where we ablated in this one little spot. We then induced the second one, and there was another biatrial flutter. This is a ripple map if you prefer to look at that. Sort of a broad breakout on this side of Bachman's bundle, goes all the way around, comes through this little choke point right there, and then breaks out again. So just another way of looking at it. We did get another biatrial flutter, and we found another biatrial connection just under the right pulmonary vein, and this terminated that flutter, and then she was no longer inducible. She's actually been pretty good. She hasn't come back with further ATs or AFib since then. So we didn't actually do anything in the left atrium. We cut these connections. Now, what if we had cut the connection in the CS somehow? Then she would have dissociated her right. I think we cut every connection between her right and left atrium here, and then the other one I showed on the right atrial side. I think we cut every connection in her right to left or left to right, except the coronary sinus. So obviously we don't want to do that, because then she'd have a completely dissociated left from right atrium, which has actually been reported.
Hey, Greg, can I ask a couple questions?
Sure, absolutely. Mm-hmm.
One was in terms of endpoints for ablation, aside from targeting the clinical, what do you try to get when you're done with these cases?
Yeah, so it depends. So obviously, the first case, I'm trying to determine that there's lateral mitral block. And at the end, I showed a case, I think, just trying, how do you determine that? But do it mostly with, putting a pen array in the left atrial appendage and using ablation and using differential pacing. So I'm looking for block across that line. In the first case where that breakout was underneath the appendage, you would have seen that in sinus rhythm. You would have paced the endocardial surface and seen it break out on the other side, and it wouldn't look blocked. So you have to look for differential pacing for block. One of the other problems with these anterior lines sometimes is you get really late left atrial. So this pen array is in the left atrial appendage, and you've got right atrium to CS. It can't make it over the septum to the left atrium anymore, or to the left atrial appendage, so it's got to go all the way around the coronary sinus to activate the left atrial appendage. So the left atrial appendage is actually often activating within the QRS, and that's not necessarily ideal. For the anterior lines, that's what you look for. So I'm looking for particularly the ones where you draw from the valve to the left superior pulmonary vein. The left atrial appendage will always be late. So in that case, you're looking to see it comes after the distal coronary sinus. If it's equal with or before the distal coronary sinus, you haven't blocked it. And so the anterior lines are pretty easy to figure out, but usually it's much easier if you have two catheters. And here, after block, this was before block, so it's almost simultaneous, and here it's moved much later. But it's not ideal probably to have the left atrial appendage that late. So this is one more case.
Sorry, before you move on,
yeah.
there's one other question. If you could just clarify, I think they're trying to figure out why you chose to ablate that last case near the SVC or on the right atrium rather than a lateral line.
Yeah, so you could have. I think a lateral line was possible when we mapped it out and saw that it was in the right atrium, and when I put the catheter, and we saw that little choke point, and I put the catheter on that choke point. So let's go back to that. Here, there was this choke point near this SVC where the circuit kind of came and squeezed through this little spot. When I put the catheter there, it actually terminated tachycardia. So just catheter pressure there terminated one lesion. And so we re-induced it and then ablated it and it terminated again. So we knew kind of a single lesion there was probably going to prevent this particular flutter. Then there was a new one that broke from lower on the septum to the right veins, and we did that. The lateral lines, it's a lot more, it's a lot of work. You're talking about, again, doing the other side of the ridge down to the valve in the CS. And she already had a blocked anterior mitral line. So what's the other thing that would have happened with the lateral line? Potentially. We blocked off. You might isolate the entire left atrium. So, I mean, you're at risk of that, certainly. I mean, there are right to left connections still before we did that, but if you did a lateral line with a line of block anterior, you always have to be careful. There's a chance you might isolate that whole chunk of atrium. So that's another potential reason. I don't think that would have happened in this case because above this line of block, there were still roots from right to left, but they were pretty potentially tenuous. And if you made another line, you could have the scenario where you might end up isolating. Does that make sense?
Yeah, I think it does. And someone wrote through the chat rather than unmuting with concern about isolating the appendage. I have a case exactly like this where that happened when I.
Yeah, it probably wouldn't happen with a line this low because there are ways to get over to the left atrium that are above this line as we showed. So here and then on the septum. But if your line is from here to here, for instance, or here to here, you may have cut off all the right to left connections to the left atrial appendage. And so if you were to complete, and you had a complete line here, then you went to the lateral line and did that, you could easily isolate the whole left atrial appendage. And I know the German Karl-Heinz Cook group, or I think it was his group, was using that as a strategy to isolate the appendage. And they had an extremely high rate of left atrial appendage thrombus, even in sinus rhythm. So it's one of those things where if you're going to do that, you better be prepared to probably ligate the left atrial appendage in some form or fashion. So, because they're going to be very high risk for stroke. Okay, do we have a few minutes left, or I can show?
Yeah, you want to go through another one of your cases?
Yeah, I have another one. So this would indicate a little bit about how, said, how do you tell that you have blocks? So this is aimed at that. So during, if you can put up the poll, that'd be great, because then I can move to the figure quicker. During RF catheter ablation, perimitral flutter occurs. There's wide antral PVI and isolation of the posterior left atrium. After conversion to sinus rhythm, a multipolar catheter is placed in the left atrial appendage, and the electrograms shown in the figure are recorded in sinus rhythm after a line of ablation from the anterior mitral valve annulus to the left superior pulmonary vein. Based on the activation sequence I'm about to show you, you can draw the following conclusions, which are on the poll. So here's the signal. Here's the line we tried to, that was drawn, left from the mitral valve annulus back to the left superior pulmonary vein. We put the pen array catheter sitting in the appendage. So that's here. And this is the right atrium and coronary sinus. So based on this, you can answer what you think is going on. And I'd say that this is probably too strongly worded, can draw the following conclusion. it's probably most likely scenario. So yeah, it's difficult. I know from experience what the answer is here. Even in sinus rhythm, if you've drawn this line and you have simultaneous activation of the appendage and the distal coronary sinus, it's not blocked. It doesn't matter. You can go pace right up against the line, you'll see the same thing. And what's happening is, the wavefront, again, there's right to left activation of the septum. And so when that happens, you get activation here, and you always see sort of simultaneous activation of the appendage and the coronary sinus. Sometimes the appendage will even be earlier than the distal coronary sinus, because activation is coming around the coronary sinus, and it's also coming through the septum, over the septum to the appendage. When they're tied, this line is not blocked, because what has to happen if it's blocked is activation comes up to this line and is halted completely. It had to get to the appendage. The only way you can do that is to go around the valve and get to the appendage. Now, it could be over Bachman's bundle, it could be, who knows where the line, it's a long line, so where one of these lesions is not creating block, or maybe multiple. But if this is blocked in sinus rhythm, you'll see it'll go around the coronary sinus and activate the appendage late. In fact, the posterior part of the left atrial appendage will be the earliest part that activates. And so I can tell you that more ablation is going to be necessary. And here is the moment we get blocked. So here's the current condition. You drop a line and you see the distal coronary sinus and the left atrial appendage are pretty much simultaneous. This electrode here is posterior. And so the other thing you notice is that the anterior part of the appendage is activated first. The posterior part of the appendage is activated later. When you get block, and so from this beat to this beat, block was achieved, the posterior part of the left atrial appendage is now early, and the anterior part's late, and they are after the coronary sinus. So it's got to come all the way around, go through the coronary sinus, and come up posterior to the appendage, and then activate the anterior portion. So this is what you see when you get block in this particular line. Now, the lower the line, the lower this line, the more you have to kind of put catheters on either side to tell what's going on. So you always want to, the nice thing about this is the left atrial appendage is sitting right next to your line. So that's why this works. If the line's down here, sinus rhythm, it may be difficult to tell. So what you want to do is put in a catheter right on the other side of the line and pace this side. Sinus rhythm, if you put your catheter right next to the line, is a pretty good indicator, but we do always check. So we will put a catheter here and see that this relationship is the same. But I can tell you in sinus rhythm, you already know this isn't blocked. We will pace just on the other side of the line and you'll see the same relationship. This posterior part will be early as part of the activation sequence, being posterior to anterior in the appendage. This is sort of, I think, a final lesion, or an example of a lesion set where you make this line of ablation, and it has to come all the way around and activate the posterior left atrial appendage first. I wanted to just go a second because people ask this question: what are we doing for our persistent AF lesion set in terms of settings for RF? I've changed this over time. I've gradually been creeping up on power with the idea that you cut down the duration, and we use certain safety checks. So in the anterior left atrium, I've moved up to 50 watts. I will set I'll set a actual time maximum 20 seconds. So if the contact force is low and the impedance hasn't approached 20 ohms, I'll go a full 20 seconds at 50 watts. You can use ablation index, and when it gets around 500 to 550, that's another reasonable endpoint. I've gone actually from 30 watts posteriorly. I went to 35 for a while, and now 40 watts, but the maximum of 10 seconds at 2 cc flow with the thermocool, not a thermocool SF. So I rarely actually go 10 seconds. It's more like 6 to 8 in most cases. The impedance usually, if I'm over the esophagus, 6 to 8 seconds. If I'm away from the esophagus, maybe 10 seconds at 40 watts, 2 cc flow, never seen char. We have a large experience that we'll publish soon that shows we've never seen a stroke using 2 cc flow and limiting the duration and using the thermocool catheter, not the thermocool SF catheter on the posterior wall. And then within the coronary sinus, I cut the power to 30 watts, maximum 20, but often could do about 10 seconds. We found that pops seem to occur as you get close to 20 ohm drops in the ventricle. We've seen that repeatedly. When we get close to 20 ohm drops, so around 18 ohms, I'll come off ablating. I put the, so when we're showing the Carto, we always have this screen up so that we can see impedance, and we'll watch the curve. We'll have our cartographers set an upper bar at the beginning impedance and then drop it down 20 ohms so that we can see when the curve comes close to the 20 ohm bar, we'll come off. So we'll stop earlier than the preset. But we do have a fail-safe on the posterior wall to set it for 10 seconds max, so you don't go over that 10-second limit when you're going at 40 watts, for instance, and on the posterior LA at 2 cc flow, with the concern that longer duration may lead to char formation potentially. But at that short duration, I think it's quite safe. Although I do have less data for 40 watts, lots of data for 30 to 35 watts.
Greg, there was just a question if you could clarify about using the 2 cc flow. How do you do that? And
yeah, you have to, it's sort of an off-label thing. You need, so first of all, I don't use the SF. Let me repeat that. I don't use the SF. I use the thermocool. I don't know whether you could get away with the same settings with the SF. You have to tell the system, the smart ablate, which happens to not be so smart in this case because it doesn't know the difference. You can tell it that it's a 4mm tip catheter, and so the background flow won't change. So you're going at 2 cc, you come on ablating, it doesn't turn on the pump because it thinks it's a 4mm solid tip catheter. And so it will then ablate at 40 watts with 2 cc flow. I set a temperature limit of like 50 degrees. It never really gets there. Even with 2 cc flow, the temperature is always maybe in the low 40s at the most. But that's how you have to do it. And that's only with Carto. I haven't really done this with other mapping systems because they're not as easy to fool, I think.
Greg, recall we also had to switch over to a power controlled mode instead of
yeah. So that's what the 4 cc. So for the 4mm tip, you switch to a power control mode, 40 watts with a cutoff temperature of 50, and basically, 10 seconds. 10 seconds max. If I'm over the esophagus, I'll try to do 6 to 8. There I'm looking at electrograms too. So if the electrogram's gone, 6 seconds, I see a nice impedance fall, then I'm done with that lesion. It works pretty well. And sort of the other thing that this is sort of our current persistent AF lesion set, particularly when they have scar like this. So patients who have no scar, we might just do the PV. But many patients we see have a fair amount of low voltage in the left atrium. What we do is veins, the posterior LA. This patient had already had the veins done and came back with AFib. So we did the posterior wall. And then what we do is this thing I talked about. The ridge had already been done on the prior ablation, so we did the anterior side of the ridge, carried it down to the valve, and then go in the coronary sinus and try to eliminate local coronary sinus potentials. So sort of more or less isolate musculature in the coronary sinus. So this is kind of what we've worked at. This lesion set has worked, I've been impressed at how well people have done with this. I think this idea of creating a more durable lateral mitral line is the key. and taking out some potential CS triggers, and the posterior LA has worked for us anyway. I mean, we'll have some data published at some point, but I think this is what we are doing currently. At least Travis and I are doing it. All right, I know it's getting real close to 8 o'clock. Are there any other?
Yeah, maybe I can
questions?
ask one or two more. So this was a question about epicardial connections, because we know there are some. Have you come up with any tricks to make sure that your lines are transmural aside from pacing? Do you do high output pacing on the line, sure it doesn't capture anything along those lines?
Yes, so one of the things for the posterior LA is it's very common to have epicardial sheet that's still active. Even you can ablate the endocardium and you'll often find something that captures in here. So the way we finally go about this is we'll go in and we'll pace back and forth across the wall in this entire boxed region, and any place it captures, if we can do it safely, we will re-ablate it until nothing captures at high output. So that is one thing we do for the posterior wall. For these other lines, you know, again, done a lot here. I will pace along the endocardial aspect to see if anything captures, and then make real sure that I pace close to the line and record all along the edges of this line to make sure there's no leak along there. It's really easy to fool yourself that you have block in these scenarios. The first thing I'll do is put in a catheter here and look to see that the CS is reversed. But then I'll go along the line and make sure there's nothing else that might be leaking through there. It's not easy though. I mean, I think I'll look forward to the day when we have potentially an energy source like electroporation that could, you know, reliably give transmural lesions without worrying about damaging arteries and veins and nerves and esophagus. Maybe then we'll take the next leap in terms of, you know, these kind of lesion sets then might be perfect because you know that the durability is really high. And then you can start to test these lesion sets more accurately. I mean, you test strategies, but you don't know whether any of this is blocked, right? I mean, but what we do is those tricks to try to make sure, and we've had pretty good success. I mean, these are posterior wall, if not completely isolated, almost never has, you know, the equivalent of leak all the way through the posterior wall when they come back. So there's always like the equivalent of a roof line. And most, if not all, of the posterior wall is pretty well isolated when they come back. And this actually helps improve the pulmonary vein isolation as well, I think, for RF.
Do you have any thoughts on the combined surgical and EP approach, you know, involving your surgeons at some point?
We have one operator who likes to do that and has been doing it for a long time. I'm not that impressed with it, honestly. I think what they do, it depends on the surgeon. We have some surgeons that seem to take out like this little spot here on the posterior wall, you know, and you know, if that's all they're contributing, I don't see the real advantage of that. You know, again, you could say doing the posterior wall epicardial and then you being able to do it endocardial may improve the durability. That's really I think that's really probably what they contribute to the posterior wall part. But then again, you know, if they can manage the appendage, so that may be another advantage to doing that, where if you can manage the appendage at the time of that combined procedure, and, you know, we'll see the results of the Maze trial and some suggestion that if you can take out the appendage safely, that may be something else they can add that we can't do easily.
So the most of the published data that came out of our group here on the hybrid approach is not exactly the same hybrid approach we're able to do now. I think because we're using a new in-contact catheter, and having kind of seen both, I think the one thing with the approach now is, you know, now most of our group is doing this type of posterior wall lesion set, and we haven't seen that much esophageal heating. So if we're able to isolate the posterior wall, there's just the patients tend to do better. Most of the patients who get the hybrid, they've got chest tubes in, they have a drain, Their recovery seems to take longer. I think the only benefit to that is they've been doing combined lariat through the epicardial access. So for those patients that we've decided to take out the appendage, you know, by a lariat, and then they'll do the combined. But yeah, it just seems like the post-op course for those patients is definitely more challenging.
Hi, Sharon. How are you?
Good.
Your
Nice
voice.
to see you guys.
Good.